everyone, and good afternoon. Thank you for joining today's webinar focusing on adding sleep medicine to your practice. My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator for today's presentation. If at any point during the presentation you have questions, please type them into the questions section of your control panel and we will cover them at the end of the webinar. Please make sure that your volume is up and any large applications are closed to ensure a smooth connection. This webinar is presented by Henry Schein Dental and no CE credits are being offered for attending this presentation. Our speaker today is Dr. Daniel Klauer. Thank you, Dr. Klauer, for being here today, and we look forward to your insightful presentation.
Thanks for having me, Adam, and enjoy the opportunity to spend some time with you guys, and appreciate everybody's attention. So I'll get rolling here, and we'll have some time for questions at the end. So objectives today, kind of in the presentation outline, is how to determine if sleep medicine is right for your practice. So what we want to talk about is some things that you want to look at and identify before you jump into this pool, if you will. And I'll talk to you about some of the things that I went through as I came to identify if it was right for my practice. We'll talk about end-to-end workflows to diagnose and treat craniofacial pain and sleep disorders. So we'll talk about the process from getting patients in the door, getting them sleep studies, and getting them treated, and on the pain side, collaborating with your physician colleagues to help these patients. And then we'll review some of the technologies and investments recommended for this type of practice. There's a bunch of different ways to skin the cat, and I'll kind of share how I do it and then some thoughts on that. And then we'll talk about the ROI of adding sleep medicine to the general practice. So we all got in this to help people and do what's best and be advocates for our patients. But you know, when we do add a service or a line on them, we got to make sure it cash flows, because if it doesn't cash flow, then we can't keep offering that service to patients and continue on. And then we're going to go through some typical clinical case reports that we see, and typically, you know, there's pretty straightforward, but we'll kind of share with you what those are like. So some disclosures. So I do work with the consulting company where we consult dentists on how to really get traction with their training in TMJ and sleep treatment. And so we do some business consulting on that. And so it's all things practice management, really not so much on the, not at all actually on the clinical side. And so I do want to disclose that. And then I'm a consultant for dental imaging technologies. So it's an imaging company. And so we do some lectures for them and such. And then I am receiving an honorarium for this webinar. And this is what I do and how I do it. So it's my thoughts and opinions, and always open for discussion and conversations with colleagues. But it's by no means is the end all be all, but it's just what I do in my practice. All right, so that's my family. We got a 7, 5, 3, and 2-year-old. So a joke that my wife is the true pediatric sleep expert. She got all these kids sleeping through the night early on, and that's our crew. That was just before Christmas. So work at and operate the TMJ and Sleep Therapy Center of Northern Indiana. We also have 2 myofunctional therapists, and so kind of an offshoot of that is the Myofunctional Therapy Center. And we are in South Bend, Indiana, so we're in Notre Dame country. So big Notre Dame fans, but we do accept patients of all collegiality and stuff like that. So we do see some Michigan fans since we're right on the border there. So 2 websites if you want to learn some more information about us and what we do: tmjsleepindiana.com and drdanielklauer.com. And so feel free to visit those. So South Bend is located right on the border of Michigan. So Northern Indiana, Southern Michigan. We're about 90 miles from Chicago, about 100 miles from Indianapolis, and about 3 hours from Detroit, 2 hours from Grand Rapids, and 2 hours from Fort Wayne. So right just east of Lake Michigan. So we usually get a lot of lake effect snow, and that's where we're located. So where we are, we have about 161,000 people in a 5-mile radius. Average household income is $49,000 to $58,000. So pretty straightforward area. Nothing crazy, but great place to live, great place to grow up. It's where I'm from, and moved back here in 2010 after dental school. So we're 100% fee for service. So we do courtesy medical billing. So we have a billing company that processes our claims, and works with the patients on that, but we're 100% fee for service. A little pearl to start is probably a line I say every day, and I'm sure you guys all have your different version of it, is cost is only an issue in the absence of value. So at the end of treatment, I want to be able to look the patient in the eye and have them say, you know, I got more in value than I'm paid in cost. And I think that's how, you know, 7 years later of doing this, we're still up and running, is because we always exceed on the value side of things. So this is kind of a mantra we have, and our team needs to exude as we're working with our patients. So this is a kind of an external view of our office technically in Granger, Indiana, so just east of South Bend. And inside the office, we have waiting room where we can do some presentations, and then you know, we have a little credenza, we have a 3D imaging, so we utilize the iCat Flex for our imaging needs. Treatment rooms are pretty basic. You can see behind me, we have a dental chair that does fold all the way back, and the leg comes up a little bit, which is nice, but it sits upright, which are most of my conversations are like that. And then we have a monitor here for a patient so we can pull up their sleep study and go through it with them, pull up their imaging, pull up their posture photos and stuff like that. And then we just have slow speed Dremels in each room. This room actually in the corner has a high-speed handpiece, the only room in our office that has that. We have 6 operatories, so we have 6 patient-centered rooms for treatment that are utilized throughout the day, and then a little break room, and then here's a picture of our team. So we have 5 clinical assistants, we have a nurse practitioner, and our admin and support team here at the office. So I'm a full-time clinician. I see patients Monday through Wednesday in clinic, and we'll see about 35 to 50 patients a day, and I'll start anywhere from 35 to 50 case starts a month. Usually see about 5 new patients a day. Today we saw 5 new patients, and it's myself, a nurse practitioner, 1 myofunctional therapist full-time, another one that helps part-time, 5 clinical assistants, 4 admin, and then 1 marketing development person to help with outreach and keeping communications with our physicians and dentists that refer to us. And so we'll see about 75 new patients a month. It really depends on how many days I'm seeing patients, and if our nurse practitioner is seeing patients on those Thursday, Fridays that I'm not in clinic. And so 100% TMJ and sleep therapy, so headaches, migraines, sleep apnea, snoring, sleep disordered breathing, upper airway resistance syndrome, and myofunctional disorders is what we do. No crowns, fillings, cleanings, or anything like that here at this office. So how did this all start? I graduated dental school in 2010 and started associating in a dental office, and the dentist I worked for was really progressive, very organized, and had good systems in place. So as I started to work for him, I had to take everything that was in his brain and try to understand it so that I could emulate it. So I put together this standard of care document at the general office, like the first couple months I was there. And what that just consisted of is, okay, we do a medical history update. When do we take the necessary radiographs, oral cancer screening, fluoride, perio diagnosis chart, prescription guidelines, common prescriptions we prescribe. So I laminated this and I put it in every operatory in the office just so I had it as a reference for when I was seeing patients. So I needed to kind of put down what he knew as best I could. So I had a system to follow. And I'm sure all you guys are reading practice development books and leadership books, and all talks about systems. And so that's why this type of practice really spoke to me. So in 2013, we were interested in buying an iCat. And so we went to this conference in Denver, Colorado, and Dr. Olmos spoke. And Dr. Olmos spoke about craniofacial pain, TMD, and sleep. And first time I heard him speak, which is a couple months later, it literally was like a light bulb went off, and it realized that, oh my gosh, we have all these patients right in front of us that have these problems, and we weren't taught in school how to deal with them. But he had a system for that, and so that's why it really spoke to me. So I have this video of my 2 boys here, And picture me as being Carson on the beanbag there, and Dr. Olmos's lecture being the little blonde boy in the blue here. And this is really kind of what it felt like.
Nicholas!
Just kind of got smacked in the face there and realized that
You've been
there's a lot of stuff we can do for these patients. So Dr. Olmos's courses, the way my first course was set out was there was 3 sessions, and I'm going to go through what those 3 sessions are, and we'll give you more information if that's a course you might be interested in. And I'm going to go through some of the great courses out there and such. But what I loved about Dr. Olmos's course is he had a system. So he had a flow chart for treating these type of patients, whether it's symptomatic palliative care, treatment of apnea, with CPAP, without CPAP, ortho needs. And so he had a system that I could follow from a treatment standpoint to get these patients treated and healthy. And so what I did was January of 2013 was my very first course in this. And so after the first session, I learned how to screen patients. So for the next month, I screened patients, and we screened 200 patients in 3 weeks, which will do the math on how many patients in your practice are probably suffering from problems like this. And we're probably going to predict low numbers, but nonetheless, I scheduled exams into the future later into February, because I really was just focusing on screening patients first and then worrying about doing exams later. So after session 2, kind of learned how to do a proper exam for craniofacial pain or dental sleep medicine. And then I performed exams, came up with some diagnoses on the TMJ craniofacial pain side of things. And then if they needed a diagnostic sleep study, make a proper referral to an outside facility or physician partner to do sleep tests on. And then after session 3, started delivering care. So January of 13 was my first course, and then March of 13 was the first case I started in treating this. And then I kind of hopped on a plane and was traveling around everywhere for about 2 years to do this. And then it was June 1st of 13, so about 5 months later, that I stopped doing general dentistry and just have done craniofacial pain and sleep since June 1st of 2013 full time. So Dr. Olmos says it's art if only I can do it, it's science if I can teach others to do it. And so Dr. Olmos took someone like me, didn't know much about anything from pain and sleep standpoint, and he believes delivering care to the level that a seasoned practitioner like him is over the years. So if we have a scientific model and method of doing this stuff, it should be reproducible for other practitioners. So to give you a timeline of what we went through, and a lot of people always ask this because they want to know how I got started and how you get to where you're going. And again, this is what I did. So everybody can do it their own way, but this kind of gives you a little lay of the land. And these are the questions that I most commonly get asked. And so that's why I wanted to provide it in the webinar today. So in 2013, this is what we had. We had 1 treatment room to work out of because we had a busy general practice. Then in 2014, I hired another assistant and we got 2 treatment rooms. And then in 2015, we retrofitted some of the office and we got 3 treatment rooms and 4 assistants. And then in 2016, we had to move into new space. So we moved into some new space that we're in now, and we had 5 assistants, 5 admin, and 6 treatment rooms. And then in 2017, added an assistant, kept the same number of treatment rooms. We're still in the same facility. And then in 2018 to 19, we added a nurse practitioner, a myofunctional therapist, and then we actually needed 1 less assistant overall because one of those assistants became our myofunctional therapist. And then in 2020, starting January 1, have 2 locations in Kalamazoo, Michigan and Fort Wayne, Indiana that we partnered on with some colleagues that are now functioning part-time for right now, probably will be full-time, of pain and sleep centers that we work with, and one's about 2 hours north and one's 2 hours east of us. And 2021, probably get a new building, have some increased space, some room for community lectures and trainings and stuff like that. So where are these locations? So Kalamazoo, Michigan, about 2 hours to the north, and then Fort Wayne, Indiana, about 2 hours east and a little south. And so here are the partners in those locations. So we have Dr. Chad Thorpe over there, and then Doctors Chenoweth, Presser, and Regan with the Fort Wayne practice over there. So I was communicating with both of them today as they were seeing patients and such. And so this is our collective whole group. We had to get together with all the offices to talk strategy, talk shop, and go over clinical protocols and everything. And so cumulatively, these are the group of people that we work with. So back in January of 2014, this is what my schedule looked like. We had, and I do have permission to show these names. We had, Michelle and Crystal running 2 rooms, and then now we run 5 or 6 rooms. We had an assistant off here, and that's kind of what the schedule looks like. So a day like that was 6 new patients, 5 starts, 8 deliveries, 4 recalls, some progresses, and appliance adjustments. And so today was a similar day to that. We had 5 new patients, started 5 cases, and had a handful of deliveries, recalls, and progresses scheduled in there. And so the nurse practitioner has been really instrumental in helping me with these follow-up care appointments and some of the consultations, because just like hygiene, if you continue to accept new patients, you got to have more support personnel, because these patients, if they're compliant and they're wearing their appliances, you're going to be seeing them every year. So first, we got to determine if it's right for you. So what is your victory? What do you want to accomplish? If you're looking to just add a revenue line item to your practice, that's not the intention of going into this. And that's not what motivated me, and really hopefully doesn't motivate others as it goes into it. But is it the right thing for your practice and what you want to do for your patients? And most of your patients are screaming for help with this, and they don't even know it. So every patient that comes into our office, we write down what's their victory. We want to know what they want accomplished, what they want from this appointment. We put it on a Post-it note, and I have them right here. We put it on a Post-it note, and we attach it to their paperwork, and then we put it on the computer monitor, so it's front and center for when I come in the room. So I'm always speaking to why they're there and what their victory is, what they want accomplished from today's appointment. And so I would challenge everybody here to figure out, okay, what does a victory look like for you in this dental sleep medicine, craniofacial pain world, and how are you going to go get that, and write down some goals of what you want to accomplish in that. So we wrote a book for our patients. So the book is called Achieve Your Victory. And so it's a book of about 10 patient examples walking through what we do for our patients. Now, most of you know that have started to dabble in this. The case conversion can be a big problem early on, because they don't come to the dentist for these problems. So when you start to bring it up, they're like a little perplexed as to why you're bringing it up and not their physician. So what we do is we mail new patients this book before they come in, so they have a sense of what we do. Also, if they're scheduled quickly, like they're coming in 3 days, we email them a chapter pertinent to their chief complaint. So typically we know if they're coming in for a pain or sleep problem based on the notes from the referring provider. And I'd say broken down somewhat evenly, we get 1/3 from patients and internet, 1/3 from physicians, and 1/3 from dentists, and that kind of makes up our new patient flow. So this book goes out to our patients as a resource for them to read about me, read about my team, read about what we do and how we operate before they come in, so they have some familiarity with us from the get-go. So first step would be to take a course, discuss it, and make a plan. So you want to get out there and just get exposed to the nomenclature, the way an exam goes, what goes into it, the relationships you need to foster, which we'll talk about in a bit, and all of the nuances that go with it. So there's some great academies out there, the AACP, the AADSM, the AAPMD, and then I just listed some of the lectures. There's a ton of good lectures out there. Dr. Olmos, Elliott, Spencer, Smith, Viviano, Tucker, Patel, many out there, a lot of people that I know and have respect for, and then companies like Henry Schein, really supportive in this industry and really put out good information. ICAT, Braybound, BioResearch, Sleep Cooper Solutions, Ormco, all companies that you're probably familiar with that have good information out there. So your academy-like courses, there's individual doctor courses, and then there's industry-sponsored courses by some of the vendors. So general screening. So what does that look like? So in the general practice, what we did is this was kind of a one-page screening form that we used in our general practice. And what you do, and you guys will all get a copy of this, the first half of it is some questions. Now, if you ask a patient, have you been told to wear a CPAP? And they say no, you kind of need to ask a follow-up question. So you've never been told to wear a mask at night, and they'll go, oh, a CPAC. Yeah, I have a CPAC, it's in my closet. So sometimes they don't know what you're talking about. And then do you take medications for headaches? A patient might say, nope. So before you go to bed, you don't take any medications? Oh, I take an Advil PM every night, but I just always do that. So what you'll find is you got to ask follow-up questions to all of these questions. I've had patients not check off diabetes, and I say, but you're taking metformin. Yeah, I know. So you have diabetes? Well, no, I don't have diabetes because I take my metformin. And they're not trying to lie to us, but they're just not being truthful because they don't know what they don't know. So you got to ask follow-up questions. And then Stop Bang and Epworth Score are two scoring systems that we use too. And so Stop Bang is a series of 8 questions, and then the Epworth Sleepiness Scale is utilized just to gauge the level of fatigue and tiredness and sleepiness, really. But the insurance companies tend to like the Stop Bang, but nothing replaces a good medical history, good conversation with the patient, and then getting this information to the right provider. And I'll talk about how we started off doing it in a little bit. So I just wanted to go over some basic terms and definitions since this is kind of an introductory lecture. And so 26% of adults suffer from OSA and 80% are undiagnosed. So what the literature shows is that about every 4th patient we see today may have obstructive sleep apnea. So that's 1 in 4. So if you have a busy hygiene practice, you probably have a lot of patients with obstructive sleep apnea that, and 80% of them don't know they have it. So some basic terms and definitions. So central sleep apnea is a neurological disorder, occurs when the brain fails to send signals to the muscles that initiate respiration. Obstructive sleep apnea is when the soft tissue of the upper airway collapses, causing a blockage. And breathing stops for at least 10 seconds or longer and happens throughout the night. Obstructive sleep apnea is a life-threatening medical condition, and some literature says that it takes an average of 8 years off a person's life if left untreated. So some serious stuff that we really shouldn't be ignoring. OSA stands for obstructive sleep apnea. Apnea is a total flow limitation for at least 10 seconds with a 3 to 4% oxygen desaturation. And then we have hypopneas, which is a partial flow limitation with at least 3 to 4% decrease in oxygen saturation. And then ARERA is a respiratory effort related arousal. So that's where we have some respiratory effort associated with increased brain arousal activity. So RERAs right now can only be detected in lab studies unless you have a take-home study that has some EEG leads on it. And then AHI is the apnea hypopnea index. And so that's an index that's used to score the studies, and it shows the number of apneas plus hypopneas per hour. And then we have RDI-REI, which is respiratory disturbance index or respiratory event index. And so you'll see these acronyms used throughout the sleep studies based on the sleep physician and the scoring criteria they use. So REI-RDI shows RERAs, apneas, and hypopneas per hour. Dr. Christian Guilleminault, who unfortunately passed away in 2019, is probably one of the godfathers of sleep. He came up with the AHI index, and from the podium, many of you have probably heard, he said the biggest disappointment in his career was that AHI index because it wasn't meant to be the Bible, it was just meant to be a guideline. And it's kind of used as the Bible when it comes to insurance guidelines and such. So with adults, normal is less than 5, greater than 30 is severe, and kids, normal is less than 1, and greater than 10 is considered severe. And so these are just some guidelines that are put out for these disorders. So here's a quick example. So here's a sleep test from June of this year. Patient had a sleep study for fatigue, couldn't figure out why he was so tired. So the sleep study came back, and the diagnosis was normal. And right down here it says this diagnostic polysomnogram did not meet diagnostic criteria for obstructive sleep apnea. Clinical correlation is advised. So it was saying this patient doesn't have apnea. So he came in for jaw pain, and when I looked at his sleep study, his AHI was 4.5. So that's CMS standards. They use AHI, but the American Academy of Sleep Medicine goes by RDI, which includes RERAs, and his apnea index RDI was 23. So Medicare guidelines score him as normal, but American Academy of Sleep Medicine scoring guidelines score him as moderate apnea. So he got no treatment because you score based on the patient's insurance guidelines in this case. And so he was really, really mad when he came in, and I told him his sleep study was consistent with what appears to be moderate obstructive sleep apnea if scored by the ASM guidelines. So I recommended he meet with the sleep physician, and he got really mad because the sleep physician told him he was normal. So we put together a patient victory summary for all of our patients to explain what we go over with them. And so he was referred in by an orthopedic surgeon for jaw pain. And we took his history. He wanted to be able to chew without pain, but we took his history. His jaw pain was secondary to probably his nasal obstruction and his obstructive sleep apnea. So we identified his chronic nasal issues are due to this big bone spur. And then as we look at his jaw, it's starting to lock and catch. So we have these situations where we have normal anatomy, which we show patients, so they have a kind of an idea of what normal looks like, and then we illustrate our process to them. So this is the process at our office with our patients, and this is his diagnosis, his personalized treatment plan, some of the things we're going to utilize, and then we give it to the patient so they understand what was diagnosed and what was done. So we didn't diagnose apnea, we diagnosed his jaw joint dysfunction, but we said, hey, we can't really separate this, and we need to get you in front of a sleep physician to get your apnea treated and get that nose addressed. And then we shoot a video. If the patient doesn't accept treatment, we shoot a video of me just kind of explaining quick 2 minutes. So at the end of the week, any patient that doesn't accept treatment, I go through their little report card, and we shoot them a video so they understand what their problem was. So let's run some conservative numbers here. So let's say you have 2 hygiene rooms, you do 16 hygiene checks a day, and you have 4 patients with likely sleep disordered breathing based on the literature. So that's 25% of 16. Let's say you work 16 clinical days a month. If you screen properly, you'll have 64 patients screened that month. So now you take those 64 patients, you make the proper referrals. Let's say 50% follow through with the recommendation for a sleep study. So that's 50%. So now we have 32 patients. Now let's say 50% of those get diagnosed and move forward with treatment. So that's 16 patients that need treatment in your office. If you do a case fee of $4,500, now could be more, could be less, depending on where you are and your fee structure. But we're talking a good amount of business in your practice and people that need help. And some would say, and I would agree, that money in these type of situations is a reflection of how many people you've cared for. And so we put together a worksheet here that you guys can fill out per your office to kind of figure out, hypothetically speaking, what your practice looks like and the opportunity that's in it. Because again, ultimately, if you make this investment of coursework, technology, and all that, you got to make sure it cash flows. Otherwise, your team and you will start to resent it and not be able to sustain doing it. You don't want your general dental practice to foot the bill for your TMJ and sleep practice. That'll only last so long. And unfortunately, we see that happen all the time, which is why a lot of people reach out to us for questions, advice, etc. So the biggest ticket item in this is cone beam technology, usually, and people want to utilize with a sleep medicine practice, dental sleep medicine practice. And it's not to view the airway portion in the throat. It's to look at the jaw joint, to look at the craniofacial development, to look at the nasal passages and all that stuff. So let's say it's $140,000. It's a monthly payment of $2,500 to pay for that. Let's say you take 4 scans on 16 days, counting your general practice, implants, etc. So that generates a revenue of $17,000. So after debt services, you're about $15,000 in revenue. And some would say, I would agree, case conversion's higher with cone beam. Patients understand more, and I think the more they understand, the better they can be compliant with your recommendations. And again, our recommendations are just to help them. I feel like what I do, there's nothing optional I recommend. I feel like it's all medically, dentally necessary. So there's different types and options to consider in this world. So we first, the right way is your way. So again, I'm going to talk about some different models and way it works, but really the right way is what's best for you in your practice when you give it some thought consideration. It's great to emulate, mirror, and learn from others, but really it's got to be natural. It's got to fit within your skin, and you got to be comfortable doing it. So you can screen and refer out. I think that's what we should all at least be doing daily. In fact, the ADA in 2017 wrote out guidelines that all dentists should be screening for sleep disordered breathing because of all the risk indicators that are visible in our practices. So I think everybody should be at least doing this, screening and referring out. And that means getting thoughtful letters, documentation, literature to the patient so they go and get a sleep study or follow up, talk to their physician. And that's really what the ADA is recommending. You can screen, refer, and treat. So you can dabble here and there and fit it in where you can. So you can screen, refer out, have the patient come back once you're have ample training and discuss what oral appliance therapy looks like, discuss the risk indications, get an order from the sleep physician. But really it works screening, diagnostic sleep study, and then an order from a physician or the sleep physician to fabricate the oral appliance. So you can screen, refer, and treat and just dabble here and there and kind of fit it into your schedule where you want to. And it's actually, ironically, it's my sleep physician calling me right now, but I tell him I can't answer it. So I have my phone out for my clock, and then screen, refer, and treat on dedicated half days. So once you start to dabble in it, probably the next step that we most commonly see is you take dedicated half days and you maybe rotate Monday morning to Tuesday afternoon to Thursday morning and just mix it in, but have dedicated half days because it's such a dynamic mental shift to be going from doing general dentistry and those type of conversations to sleep and pain conversations. So it's really, really hard to go back and forth. Now, granted, I only did it for 4 months going back and forth, but it was hard. And that's actually a big reason why I stopped doing it. Then you can screen, refer, and accept on those dedicated days. So once you start to accept patients as referrals, you really got to get your name out there and you got to have some good training behind you or good experience and relationships with dentists and physicians as you start to get referrals. But the easiest way to get referrals is to send referrals out and they come back. So you really got to communicate with your physicians and your dentists, your chiropractors, physical therapists, psychologists, all of that really need to have good communication so they know what you're about, what you do. So at that point, then you can maybe create a different entity and a presence within your practice a little bit, but it's starting to be separate so that patients almost have a little different of an experience than when they're coming in to get their teeth cleaned or get a filling done. And then next, you can do a practice within a practice, an independent brand and all. So you can have Copper Family Dentistry, and then you can have Copper Dental Sleep Medicine. So you can have a separate brand, make it independent. It can be under the same roof, but different staff, different team, different phones, and all of that stuff, sharing overhead, etc., what you will. And so that's another option to do it that can work. And then you can do an independent, separate practice and full-time, have a different location, be 100% focused to craniofacial pain and dental sleep medicine, or just dental sleep medicine if you choose. I think one of the most profound things I remember hearing was Dr. Jameson Spencer saying dental sleep medicine is easy if you're an expert of the TMJ. And so I think there's a lot of truth to that because of the overlap of those two branches. And we're seeing more and more of that. More of the dental sleep medicine courses are in fact talking about craniofacial pain, TMD, and the relationship between. So in-network versus out-of-network. I'm not going to spend a ton of time on this, but again, it's your way. There's pros and cons to being in-network. The pros is case acceptance should be higher. Patients are going to pay copay subject to their deductible. Our treatments are usually about the cost of a deductible. So treatment's about $5,000 and deductibles are $5,000. It's kind of a moot point unless they've hit their deductible. The cons to in-network, you get paid what you get paid and they can change the rate. I know our sleep physician, his home sleep test rate got chopped this year significantly. Benefits to being out of network, you're not having to do certain things, spend certain time. You kind of can pick how you want to practice. You don't have the red tape. You can you can kind of move at a quicker pace usually, and have less red tape to go through. And so a lot of the frustrations people have are being out of network. The cons is patients are out of network. A lot of people think that if insurance doesn't cover it, it's not necessary. So there's definitely a battle with that. Our 5 new patients today, all 5 were informed that we were out of network before they came in. I repeated that when they came in, and we had good acceptance today, great acceptance, 100%. So there's definitely benefits to being out of network, and am working hard to do that. I mean, we've seen SomnoMed opened a bunch of clinics across the country that didn't work out too well in network, and there's some other issues with that, I'm sure, but there's different models to do, and I think the trend is going to be going to more out of network. And then Medicare options, I'd say consult with a billing company or an expert to decide if you want to opt in, opt out, be a DME provider or not, and that's a whole, probably a 2-hour lecture on that. And then the wrong way to do it, in my opinion, is out of network and balance bill. And anytime I've done that for a family member or friends, where we say, okay, we'll bill your insurance, we'll send you your insurance, and then we'll bill you for the rest. Doesn't work out well. It's not pretty. So don't set yourself up for the failure in that. So I would not do it that way. And that's probably the most blunt I'll be about what's right or wrong in this. I think the wrong way is out of network and balance billing usually doesn't go well. Because they'll get better and then they just disappear. Or they get better and they're thankful and then they get a $3,000 bill and they're like, well, I'm not that better. So you gotta be careful of that. So wanted to throw in a couple quick cases. So Ivan, this is your straightforward dental patient that I think you all see. Comes in and he's like, hey, my teeth are grounding off, they're really flat. And you say, well, it could be apnea. So you do a workup on them, get imaging to evaluate the structures. We found out in his that he had a AHI of 13.8, so mild obstructive sleep apnea. He got his nose fixed by ENT. The ENT sleep physician gave us an order to fabricate an oral appliance. And then we did our follow-up sleep study that showed his AHI was 4.9. But we weren't done yet because he's really knocking on the door of mild still, even though we have him fully titrated to what we think is a stable position, no TMJ issues, and he's sleeping well. But what's cool is to see how much weight he lost. And then as we did a follow-up sleep study, AHI was down to, I think, 2.1. I might have it in here. But we followed these patients. So now Ivan, 5 years later, you can see he continues to lose weight, and you can really see his masseter hypertrophy is decreasing as well. And so he's doing great. Still is in the same EMA. It's going strong and hasn't had an issue with it. And I know that when he has an issue with it, we're just going to remake it because he's been doing great going along the way. So Rocco is another patient who came in. He came in with TMJ problems. So Rocco came in, he wanted to be able to relax his mouth and jaw and not feel so tense all the time. He had been through multiple orthotics with multiple different dentists and 7 different appliances over the years. And he's got dizziness, he's got anxiety, muscle spasms, and he's tired. And he's a 37-year-old, pretty healthy guy. So he's been dealing with this since 2005. So as you can see here, Rocco's got some pretty significant forward head posture, his shoulders are rolled forward, but this is what bugged him most. He had this open bite that drives him nuts. He didn't know where to bite, and he can't figure out where to bite. And so he's dealing with this, and it's driving him crazy. So we did an evaluation, and we recommended that Rocco get a diagnostic sleep study and see an ear, nose, and throat physician for his nasal valve issues and his deviated nasal septum. So our treatment plan here, what it says is we're going to start with myofunctional therapy to help keep the tongue in the roof of the mouth and help treat that lateral open bite, because I don't want to make him a sleep appliance and keep his bite in that position. It's driving him nuts. And if he does go through with braces, we're going to need to get that tongue up in the roof of the mouth, not laterally, because that's just going to impact his orthodontics. But we got to get his jaw pain under control before we do braces anyways. So we started treating his jaw joint dysfunction as we found out he had mild sleep apnea. And so we utilized a myobrace and myofunctional therapy with our myofunctional therapist to help with his jaw joint problems and his myofunctional disorders. And so it's really cool. In 8 weeks, we start to see that bite closing. And then in 8 weeks, you can see it's pretty significant. And then when about 3 months, got his bite to reestablish normal, got his tongue out of the way. So just like the tongue can push those teeth out of the way and make them crooked, make open bites, we can get him to have the occlusion socked in. So over the course of treatment, we found out he had apnea. He got his nose fixed. We got his bite reestablished. After his nose was fixed, he still had some apnea. So then we made him an oral appliance. But now we made him oral appliance on dentition like this, where his bite is nice and socked in and he feels good about it, versus making an appliance on that lateral open bite. So now you see in habituation, his tongue's in a different position. Now this is not the end all be all. He can swallow, move his neck position, change, and that airway dimension is going to change. So I would never say, oh, look what we did 100%, but it just shows his tongue's in a better position. His bite feels better, is better for him, and his head's more upright. And that's probably the most significant thing. You can see how much better his posture is. His neck pain's not bad anymore. So what we did in Rocco's case is we said, hey, Rocco, who have you recently spoken to with headaches or jaw problems? He gave us some names, and I said, would you be willing to introduce them to us so we can help them like we helped you? And so you say, who have you spoken to? And then you ask, would you be willing to introduce them to us? And so what's great about that is we get some names. So Rocco, in 1 year, brought his son in for myofunctional therapy, his daughter. His grandpa came in, or his dad came in for apnea treatment. His nephew came in for myo. His uncle had apnea. His sister had TMD. His mom, we found out, had TMD and OSA, and his brother had TMD. So in 1 year, see all these referrals that come from simply asking one simple question. Who have you spoken to? So now into the technology part of it. So in 2013, we bought an iCat. And now these numbers are just rough numbers. I could look at my invoices, but I don't remember exactly. So I kind of just went rough numbers. So don't quote me on any of these and get me in trouble. But we bought an iCat and a joint vibration analysis that measures the friction inside the jaw joint. And then we bought a Metabite, a home sleep test unit. Now the way we use the home sleep test unit is just for interim tests. We don't do diagnostic tests with them, just interim to test the efficacy of the appliances. And then we bought a laser, which I have in the corner of the room there with our 3-shape trios. So the laser is photobiomodulation therapy to help with pain. And then we got another JVA, another laser, and another Metabite in 15. And then in 15, we bought a 3-shape trios intraoral scanner. And then in 16, we bought a third Metabite and a third laser. And then in 2017, we bought another trios, because as we were starting cases, we were waiting for the trios. So when it got busy enough, we just bought another trios. And then in 2019, got a centrifuge and a kit for platelet-rich fibrin injections for osteoarthritic conditions in the jaw joint. And we've been doing a lot of that and getting really, really good results. So pace out your purchases and set goals. So set parameters for when you can purchase that next piece of technology so you don't oversubscribe yourself and get into too much debt and not able to keep the ship afloat as you start this. So these are just some of the technology pieces that we utilize. I put a pharyngometer in here. I don't currently have one, full disclosure, probably something that we'll be getting pretty soon because it's definitely has tremendous value in this sleep world. Mentor uses it all the time, and a lot of colleagues, I'm sure that you guys know and that I work with, use it all the time. So there's tremendous value in that. But we have the iCat, we have the Metabite, JVA, 3-shape trios, that's a Unico centrifuge, and then the laser. So you want to find your sleep leader to start. So you got to have someone within your practice to do that. So this is just one of our recent hiring campaigns. And so we have a fun job posting here that you guys can look at, take some stuff from if you want. So just last night, my assistant texted me, and this is what someone, as we were vetting our employees, we vet all employees before we interview them on Facebook. This is actually what came up on Facebook. It's a picture of Crazy Doll. When you've been a blank hole, but then you smoke a little weed and chill out. So needless to say, we didn't interview her, we went on to the next applicant. So as you interview for these positions, you don't need a dental assistant, it could be a medical assistant, but you want to find your sleep leader to start and really have that be the champion of your practice. So what other capital expenditures are required? You're going to spend money on professional development, so practice management help, leadership courses, etc. Continuing education on that front. Team training is huge. I brought my team to a lot of sleep courses over the years and TMJ courses to get them trained. If you think that you can go to a weekend course and come home and explain it to them who are smart and intelligent, don't get me wrong, in an hour, you're nuts. If you think you can, whatever you learned in 2 days, you can take a 1-hour lunch and train them, you're crazy. So taking time on team training doesn't mean bringing them all, but blocking out a half day to go over that stuff is going to pay off huge. And then computer hardware and software. So once you have clinical training, this is the type of stuff that we've had success with. So we have to market to the community. Then we need to attract the patients and nurture those systems. We want a great, stellar new patient experience, great culture in the office, have a process of doing an exam and treatment planning. We have to get conversion, so we got to get patients to say yes, and then keep that flow with your professionals and have that follow-up referral system, because you're going to refer out and then you need to be able to accept referrals in. So basically, to do that, you got to have administrative support, team development training, you got to have growth events and accelerators, so practice events, community events, and then the doctor is huge. You got to have good leadership for this system to work. If you want more info on this, you can shoot Heather an email at my office and she can provide that for you. But then get out and share the message. So I've had the opportunity to lecture to a lot of orthodontists. This is at the Ormco Forum. It was about 1,000 orthodontists last year. And so it was really special to be able to share with them. And that's our myofunctional therapist, Crystal. So this is what we can do. In closing, these are the type of results you get with patients. You take them from looking like this to that, like that to that, just by taking away their pain, improving their breathing, treating their apnea, etc. So you see these pretty significant changes, but you can't do it alone. You need to develop a team. So here we have orthodontists, pain physicians, oral surgeons. This is our nurse practitioner, and this is our myofunctional therapist. 2 orthodontists we work with, our sleep and ENT, a rehab specialist, a musculoskeletal pain doctor. So you got to develop your team to be able to deliver these services and help these patients around. And it doesn't happen overnight. It takes time. And so in closing, if you'd like to set up a call to discuss this stuff with Henry Schein, Adam's going to go over a few things here as we open up to questions, but you can go to this website here and your technology rep will talk to you one-on-one about if this technology purchase is right for you. And they obviously sell some of the things I discussed, not all the things I discussed, but Adam, I think you'll moderate opening it up to questions.
Yep, thanks. We do have a couple questions. The first one is from an attendee who works with 3 sleep physicians, and there are 6 pulmonologists in that practice. The problem is that they keep the patients and they only refer their problem patients to the attendee. How would you suggest resolving this issue when you still meet with the other physicians that are skeptical?
If you are diagnosed with mild to moderate, this is a choice you have. So make sure if the physician brings up treatment options, to be honest, they might forget I even sent you, and they might even forget, to make this recommendation, but it's your choice. Now, I'll tell you if I think a CPAP's better, because I want you to get better and not just do an oral appliance to do an oral appliance. So close the loop that way. And then if you're having multiple issues, sit down, meet with them face to face. Most time when doctors call me with that question, I'll say, hey, have you ever met the physician? No. And they'll go, oh, he won't call me back. Find a way to meet him, find an excuse to. And so once you meet with these doctors face to face and they see your authenticity, your training, and your compassion to helping, they're going to want to collaborate more. Most of the sleep physicians, unless they own a DME company, they're referring it to someone else. And I bet it's not a financial thing. It's probably just lack of knowledge and ease. And so we had that same problem, and you just got to keep breaking down those barriers.
All right, another attendee heard that the billing of sleep services is quite complex. How would you suggest a practice tackles this area? Should they partner with a service, or do you have a service that you recommend?
We work with MDFC, Medical Dental Financial Corporation, Tanya Evers. You can get in-house training for it. You can just say the heck with it, I'm not dealing with insurance. Personally, I think the best way is out of network and courtesy medical bill. Any insurance dollars that the patient gets is icing on the cake, and I say that. So I think last month, 12% of our revenue was reimbursed through medical insurance. So it's a small portion. So 12% of the revenue collected was reimbursed medical dollars. So not a lot. It is cumbersome. Sleep is one of the easier things to deal with if you have all the documentation and paperwork up front. And there's a lot of good people out there that teach courses in billing. I just find if 12% of my revenue comes from that, I'm not going to spend more time and effort and energy on that. I'm going to spend more time, effort, on energy on quality of care, patient experience, and then getting out there in front of doctors. But I see so many doctors spending so much time trying to crack the insurance code when it might be easier just to be out of network and focus your efforts on other stuff. And that's my opinion. I have a bunch of friends and colleagues that are in network. They make it, I think they're making it work. I haven't met a ton of independent practices with one doctor without multiple locations. Now there's definitely some docs that do it really, really well, and they've been well established in bigger cities, and they have a good presence with the insurance companies and all of that. And so not that it's not doable, I just think it's tough.
How did you locate a myofunctional therapist, and what type of training does this person typically have? Is there a certification required?
So myofunctional therapy is the wild, wild west, where there is a certification, but each state's a little different. So typically you have to be a nurse, a dentist, a physician, speech language pathologist, or a dental hygienist to be a myofunctional therapist, or a certified oral facial myologist, etc. So I had one in the area, and I talked to her and I asked her to come work at our office or see patients at our office, and she said, I'm too busy, why don't you find someone and train them? So a dental hygienist was working for me, and I said, hey, Crystal, I'll send you to all this training. Do you want to do it? She said yes. So we sent her through courses with the bunch of different academies. I probably don't remember them all, but she went through the MyoBrace program. She went through Buteyko breathing program. She went through, she got her COM, so certified oral facial myology, and she did courses with AAPMD. So there's a bunch of courses out there with myofunctional therapy. And I would say if you want to get into it, I think first and foremost, you need training in craniofacial pain and sleep. And then that myofunctional therapy is a great adjunct to all of this, and it fits within it beautifully. If you're doing a ton of ortho, you really do want a myofunctional therapist, because that'll be paramount in getting good results.
If someone has a 2D imaging unit, will the case conversions be that much different than if they had a 3D imaging unit?
Personally, I couldn't crack. I really enjoy having that 3D image, and I find that tremendously valuable in evaluating these patients with TMD, craniofacial pain, and apnea. It's super valuable to look at all three dimensions of the condyle. I had a patient today referred by a dentist, and the dentist thought the left condyle looked awful, and it looked perfectly fine. The way the condylar head was shaped in a panoramic view, it looked arthritic. It looked like it had a weird growth. But when you looked at it in 3D, it was fine. And so I showed the patient, I put him up, and so you really can't get a good view of a condyle on a 2D image. So I think it just gives you more information. I definitely, without a doubt, case conversion is going to be higher in implants with a cone beam, where you can actually show a patient how to put the implant in, where it's going to go. You show them the precision and the guidance. And so it kind of solidifies the solution to the problem they have with a missing tooth. So I believe that case conversion is going to be higher. But and I don't see why, I really don't see the role for panoramic film anymore. The radiation dose is just as low, if not lower, with cone beam. It gives you more information. And so I think it's been deemed to be the standard of care in implant placement, having a cone beam. So I do think the trend's going to be, as the radiation is probably going to get better and better and better, that we're going to see it becoming more and more common practice.
All right, we have time for a couple more. What is the best way to motivate a staff member that may not be as excited about treating patients for sleep dentistry as you?
I honestly think probably the reason they're not motivated is because you have no plan in place. So if you're just jumping everywhere and they haven't been sat down and properly trained, educated, and explained to, they're kind of being sent to the wolves and they're in a frenzy. And look, our team members, they hate doing something that they don't know how to do. It puts them in a really uncomfortable position. And so most of the time, if you sit down that patient or that assistant and ask them, hey, I get the vibe that you don't like this. Tell me about that, or am I reading you wrong? They'll probably say, yeah, I have no clue what I'm doing. And you start talking and I don't know any of this. What do you want me to chart, document? And so, yeah, you're right. I don't like it because it's frustrating and I don't know what's going on. So I'd maybe sit that team member down and say, hey, I get a sense that you're not liking when I talk about this. A lot of hygienists don't like it because it makes you run over in your hygiene exam and all of that. But the reality is if a patient needs a crown, you talk about it in hygiene. So if a patient needs a sleep study or has TMJ problems, you talk about it. If it gets long, say, hey, we should schedule you back. Let's come in to discuss this more because this is actually a serious issue that I think needs attention.
Cool. And then we've had a few people ask about recommendations for CE courses or conferences to attend to gain the most knowledge on sleep dentistry.
So I think if I'll go back to this slide. I think there's a lot of good courses out there. I think, and you guys will have these slides, but the AACP, the AADSM are good. Dr. Olmos's course I took, love, still take it. Here's some of the common speakers out on the circuit, if you will. Sleep Group Solutions puts on a lot. BioResearch has an annual conference that's awesome every year. Ormco has good meetings. Henry Schein puts on good stuff. ICAT does. So I really think like a good broad overview is important first, and really understand it so that you can make a decision. Now, if you've dabbled in it and you have a good background and you're doing cases, that's where something like what we have in Indiana might be good as a one-day immersion to walk through that patient experience, that process, touch, feel, see how it looks once you have some clinical training and stuff like that. So first, you got to get the clinical work done, and you got to get a good course out there. You guys have my my email, so if you have specific questions about a course, happy to answer that and give you my 2 cents. But I really appreciate everybody's time and attention. If you text that number here, my team will get you the slides for today, so you have those as a resource. I didn't want to make it too quick, but I also wanted to make sure you left with value and you can go back to these slides and read a little bit further. So thanks for the opportunity, Adam. I really appreciate it, and thanks for hosting.